Today I'm honored to talk about the California Reducing Disparities Project. Of the many programs that we have responsibility for in the Office of Health Equity, the California Reducing Disparities Project gives us a unique perspective to really help shape the misunderstanding oftentimes that many of us have when we think about mental and behavioral health. Particularly when we think about disparities and inequities that are experienced by the underserved communities across the state of California. And with a unique focus on early intervention and prevention that the CRDP project allows us to bring to the table, we believe that the California Reducing Disparities Project will truly advance not just our disposition as a state and our ability to more effectively and more culturally in a congruent way serve underserved communities, but really help shape the discussion and the perception on a national level when we think about the importance of integrating mental and behavioral health into our public health programs and also into our public health discussions. So as I reflect on the importance of the California Reducing Disparities Project and the opportunity and the promise that it brings, I can't help but to personalize on how important it is that we create programs that address mental and behavioral health needs of those who are underserved. When we think about those who are often underserved that come from diverse communities, from diverse backgrounds, rich heritages, oftentimes people are adversely impacted from a mental health standpoint when we think about trauma and when we think about stress. And particularly in these areas, those issues often aren't dealt with in the primary care setting, nor are they appropriately dealt with for people who are in the workplace or even in their communities. And when we look all around us, when we see poor people, people who are homeless, people who are veterans, when we think about our children who have had adverse childhood experiences, there is no greater opportunity that we have than to, from a primary care perspective and from a prevention and early intervention perspective, that we have to address mental and behavioral health, especially with regard to disparities and inequities. So of the many facets of the California Reducing Disparities Project, the community-defined evidence practices is really one of the featured highlights and really at the core of why we are doing the California Reducing Disparities Project. And you may wonder and ask why. Is that the case? That's the case because historically many of the recognized evidence-based practices have often not been executed in a culturally congruent or competent way. So oftentimes these practices that are often richly rewarded and staffed appropriately and financed appropriately often don't take into consideration what communities of color, what diverse communities truly need when we think about mental and behavioral health. Therefore, community-defined evidence practices, which we are primarily investing in through the California Reducing Disparities Project, not only creates an opportunity for us to serve these communities from a prevention and early intervention perspective, but through vigorous assessment and evaluation, we're able to demonstrate that not only do evidence-based practices work, but community-defined evidence practices not only work, but they're far more sensitive to the needs of communities that historically have gone underserved when we think about mental and behavioral health. And phase 2 of the California Reducing Disparities Project will really uphold these practices as truly being seen as best practices. And we need to invest in them. We need to sustain these practices. And we also need to broaden the array of the programs that we believe reach the diverse needs of populations across the state of California.
Hope. I cannot express how excited I was that this project was funded. For me, I had sat at the Department of Mental Health for almost 10 years, and I watched since 2004 the rollout of the mental health Services Act, and I continue to see evidence where the voices of multicultural communities were not included in many of the programs that were rolled out under the very comprehensive, more than millions of dollars in the Mental Health Services Act. And for me, this project represents that finally the voices of multicultural communities were listened to, and that we funded a project that is asking multicultural communities to identify the solutions for disparities. This represents for me the stopping of talking about disparities and doing something about disparities, but not from the systems approach, from those communities who have been most negatively impacted by the lack of culturally and linguistically competent services to serve them.
The California Reducing Disparities Project represents just a whole flipping or paradigm shift for the government. As a government civil service employee, I've just seen a big change in the way the state looks at programming. And the CRDP takes traditional or typical government paradigms of how to create better programming, takes that and just flips it on its edge, or maybe even upside down, where instead of a top-down approach to creating programs, like the government just saying to the community, this is how it will be done, it's a flip to where the government says, tell us how we should set program, how the resources should be spent. And so it just represents this new transformative way of reducing disparities or programming or coming together with community.
I think it represents a couple of different things, but the big one is that it's really an opportunity to directly address the mental health needs of California's majority, our people of color and our LGBTQ populations. We continue to see health disparities in these populations and inequities that really keep us from being as healthy as we can be, and this project was a huge opportunity to identify solutions and really develop a framework for reducing disparities.
There's so much uniqueness in terms of this project in the way that it was just built. The foundational pieces of having advocates come to a state department over at the former Department of Mental Health to inform leadership that the decisions that were being made and the impact that that would have on communities would have negative impacts, and that the importance of having to listen and move in a different direction at a time where, sometimes the bureaucracy or sometimes the leadership is stuck in a sense of doing business as usual, and having to take some courageous steps to create space and to design a project that meets the needs of recipients of mental health. And so they took a chance and they took some risks, and because of it, the CRDP was born.
First of all, I think the State Department of Mental Health at that time and the Office of Multicultural Services, led by Rachel Guerrero, needs to be commended because they actually did what Proposition 63 or the Act said it should do, which is to collaborate and listen to the community on what they wanted. And so this project, I think, is a really good illustration of that they actually listen to the community. So from the beginning, where the design of this project to the implementation, they worked and listened directly to the communities. Second, I think what's important is that this project focuses on prevention and early intervention strategies that are community defined, not evidence-based practice, but community defined. Evidence-based practices may be all right, but most of the time they are not tested on our communities. So this is promoting what we know works from talking directly with the communities.
So there were many things that make the CRDP innovative, unique, and different, especially for LGBTQ. For one thing, this was the very first time that LGBTQ populations were considered an unserved, underserved, and inappropriately served population. That's hugely important. The other thing that makes it unique was that it was based on community-based participatory research. So this project was not run by ivory tower people coming down into LGBTQ communities, asking a few questions, and then taking off. This was all done by people who are grassroots community members. Even our PhD researchers started at the grassroots community level. We went to communities first, talking to them, and then we also went back with an online survey. And then after all of that, we went back again and let everybody know what we found. That was hugely important because our populations are so used to being researched, and then we never know what happens with the information, and we never have an opportunity to say whether the information was accurate or not, or whether it was represented in a way that was useful to us. So the entire project was community driven from the very beginning to the very end.
That the findings that the CRDP process has come up with truly reflect their voices and truly reflect their cultural practices, and seeing that their cultural practices are being accepted in the mainstream, that what they feel have been important are now being adopted and actually being part of program models that are being implemented statewide. I mean, for example, we know that in the Latino community, the promotorial models were important. Having trusted cultural brokers that are from the community to go and work in the community, being that bridge is very important. In the API community, families are very important, and including families in that approach in how we work with communities is very important. In the Native American communities, the spiritual healers are also very important, and allowing for all these cultural practices to be embedded in the strategy is, I think, something that the communities should be very inspired that the study that came out of these 5 years aren't just going to sit on a shelf, but that they can really see these communities these strategies being implemented in their own communities.
Well, actually, the way in which I wish to frame that question is that we who are working on these areas in the mental health and substance abuse field should be inspired by the underserved communities. They are the ones who have been experiencing the lack of services or the inadequate services available to them. They are the ones who have, for a long time, many members of those communities who have, experienced the prolonged suffering that mental disorders and substance abuse problems cause without necessarily viable solutions. And it is them that have proven also to be resilient, that in spite of the lack of appropriate services, they have been able to survive and to thrive and to tell us their experiences. So let me tell you, personally, I feel incredibly inspired by the stories, by the voices that we have been able to hear across the state that have been instrumental for us to develop strategic directions and interventions that I hope will be helpful for the underserved communities. And I think that this goes both ways. That on the one hand, I'm very honored and very privileged to have been able to help identifying what matters to these communities. But at the same time, our hope is that what we have done and that we will be doing is for the benefit of those underserved communities, and that they collectively they see that thanks to sharing their voices that we have been able to put together plans and recommendations and also implemented practices that will be helpful.
The inspiration comes from the diversity of what communities define as best practice in wellness. There is a strong thread of cultural customs, traditions, and spirituality that reach back across generations. And those issues are long-standing and knowing within those communities. This project brings forward into the present how we can look at this define them in a culturally appropriate way through evaluation that shows that these practices really work.